that's okay with, I think you might have to click a little okay button, but thank you all for coming and welcome to the first GoMe lecture of the lecture series for this year. A little bit about us is our mission is to create an educational platform in order to help students, undergrads, med students, and beyond to interact with wilderness and emergency medicine. So just to help pique people's interests and keep them coming back and learning a little bit more. And we do this by showcasing a plethora of medical professionals in this field and allow them to talk to us, educate us, inspire us about different aspects of wilderness and emergency medicine. And we also want to help facilitate and create an international community. So we're not only here in the US, but we also do touch other places, like Australia, for example. So we are a little bit of an international. So I'm sure you guys already follow us, but please follow us on social media to stay up to date with our lectures and learn about who's going to be coming to speak to us, as well as join our mailing list, because we do send out the Zoom links and reminders to help keep everyone on their toes and just remember when we have lectures. You can also scan this little QR code to make it a little bit easier. And with that, you'll get emails about our bi-weekly lectures, about upcoming wilderness opportunities, showcases, and we are starting to offer certificate courses depending on different places of information that you want to find. Our next lecture is going to be on September 4th about avalanche rescue, which this current lecture is going to be a great introduction for, because I feel like they do go very well hand in hand. I'm also going to be dropping a little link in the chat. We are having, let's see if it'll paste. I will drop the link at the very end, but we are going to be having a giveaway based off your attendance to the lectures. You will be entered with the link for some cool prizes. And you can find more details about what they'll be on our Instagram. So go follow us. And without further ado, I'd like to introduce our speaker for today. Heiko is a senior paramedic and a rescue specialist with King County Medic 1, King County Sheriff's Air Support Unit. He's been doing this for over 40 years and has witnessed the evolution of this field back from when it's kind of sort of started to where it is now today. His home is in the Columbia, Georgia, where he volunteers as a member of the Hood River Craig Rats Mountain Rescue Team, and he enjoys teaching Avalanche Safety. Sorry, they're going haywire. As well as, to both professional and people like us. He is part of the American Avalanche Association, and both of these worlds have collided into a passion to teach and motivate fellow rescuers and medical providers that successful resuscitation and medical care can be achieved in these environments. So without further ado, I will let him take over. So the floor is all yours.
I need to redo I think I have to reshare the screen, right?
Yes.
Yes, okay. I'll share my sound and making sure I got the right one.
While he's getting everything set up, feel free to drop your questions in the chat. We'll be moderating them. And then at the end, we'll have plenty of time for a Q&A. If anything ever doesn't make sense at a point in time, also drop that in the chat and we can let him know to re-explain those things.
Okay, I'm just going to reduce some screen clutter here so I can actually see what I'm talking about here. Good afternoon, good evening, good morning, wherever we're at in the world. Thanks to Kira for asking me to come talk to you all today regarding airway management and air rescue. I think the initial intent was to talk about air rescue, but when she called, and as a street paramedic, we've been seeing fentanyl overdoses like mad, as you all know, and the news is portrayed. And airways have been on my mind. I've been managing daily critical airways through just on fentanyl overdoses every day. And it's not just that normal, give a Narcan, somebody wakes up. It is such a severe problem that we are doing all kinds of airway management. And so what I want to relay to you, nice folks, is that if you're in as a medical student, as a resident, this is the time in your career to set a tone and a great foundation of airway management. I just get out there, get your hands dirty, see these airways. Unfortunately, we take advantage of that situation a little bit with their fentanyl crisis, but this will benefit all your patients in your entire career. This is not my first fentanyl crisis. This is not, the pandemic wasn't my first pandemic in my career. So every time we encounter something difficult or a challenge, you learn from it, and it just will last your entire career. So I carpe diem the moment, and I said, you know what? We're going to talk about airway management and air rescue all in one package, because I do have to do these multi-complex tasks all at once. So hopefully I do a good job for the group and tell you about my job a little bit and the critical skills that we all have to have. So airway management does start here outside the helicopter, and it even starts way before the mission even starts. So, you know, here's our objectives. Tonight, we're going to review the factors that build competency to manage an airway. I'm going to give you a quick overview of rescue operations. What does that take? What's that skill set required to have a successful air rescue operation? Thought process and considerations of managing airways during air rescue. And I want to stress, I don't have any disclosures. There's no financial gain for me in anything that I do for my career, except for my paycheck. And this lecture is just my own insights and experiences and not an official statement of King County. On the side, or I shouldn't say on the side, but I do teach Avalanche Safety courses, and I play a trick on my students occasionally. About 75% of the way through the 3 days, during a quiet moment in the class, they're digging their pits. They think they got everything down, and they're ready to go out and be some badass skiers and mountaineers and avalanche terrain. And then I will reach down in the pit and I will say, aha, this is it. This is the one crystal that will allow us, this one snowflake. This is the one that makes it all safe. And gets everyone's attention, throws them off a little bit guard and then off their guard. And I talk about ability. And I will never question the student's athletic ability to ski a slope or climb a mountain, because we can all have that capability of doing that. We have that ability to do something hard. But the question is it the suitability? Is it suitable time or appropriate time to ski that slope, to climb that mountain? And that's the discussion we have. So you have to ask yourself, yes, I can probably manage an airway. I can probably fly around in a helicopter, but is it the right time? Is it the safest time? And is the risk benefit appropriate for this patient or for my teammates? Can everybody hear me okay before I go any further? I want to make sure we don't have any technical difficulties.
Yep, sounds great.
You're all good.
Okay, good. Thank you. So, again, ask yourself, how good are you on risk benefit? What's your mindset like? And it's another little trick I played on the students after I did the snowflake trick. We would do our compression tests and cut off a block, and it could be super unstable or stable, but regardless, we have this block. And so I'd ask the questions like, okay, should we ski this? And they would say, yeah, I'm comfortable. Well, it might be safe, but have we really thought about the entire risk benefit? So I would have the group pick up the block and I would say, now, if you're ready to do this, make this decision. And the blocks are pretty heavy. I can see Craig here just kind of holding that weight up. And I remember saying, holy smokes, this is heavy. Now imagine 50 acres of that block weight on top of you or a victim. You still want to ski it. So again, that's the thought process you're going to have to go through air rescue operations and airway management. So how good is your critical thinking skills? How good is your risk assessment? How good is your situational awareness? And that doesn't just go for you as an individual. It goes for the entire team. And as in leadership or a leadership position, you have to watch for this, or you also have to watch the entire group as a team member. So this all goes hand in hand. So again, like I said, this applies to normal airway, clinical airway management, or normal touristy, normal everyday helicopter operations. But let's combine these two disciplines in these following environments. Is it glaciated terrain? Is it crappy weather? Is it an avalanche rescue that you're participating in? Is it a suspended, stuck climber on a rock wall that doesn't have an airway in this position, but you're hanging by a cable and you have to rescue this person and manage their airway? How are you going to do that? Do you have a plan? Working in helicopters are confined spaces. We fly a totally refurbished 1974 Huey. We have two of them. I love them. I think they're the best rescue platform around. But despite they're large, it's pretty cramped in there. So how can you manage an airway in that environment? So what does it take to achieve that competency in austere or high risk or complex environments? It takes the correct mindset. And I do remember early in my career, I was intubating a patient and the word can't came out of my mouth. And I never completed the intubation because my proctor or my senior paramedic pretty much picked me up by my belt loop, carried me off the porch, told my partner to finish the ET tube, and then proceeded to lecture me about can't will never come out of your mouth. But more importantly, he said, there is no one else, future in your career, there will be no one else at that moment to accomplish that airway. So you can't go in there with a defeatist attitude. It's not hubris. It's not overconfidence. Is that it's a reflection on your path and your training and your career path to get you to this moment and take confidence in that, yes, you've seen this before, you understand the process, and you can do it because there's nobody else in the world at that moment that's going to take care of that patient. And the other aspect you need to have is, or be exposed to, is a high frequency of rescues and airway management. Patient care, critical patient care is vital. So you need to see a lot of them. And I encourage you early in your career, be busy. Don't take the easy route. Get your hands dirty, learn, absorb all that stuff. And the other factor is having high quality and frequent training with feedback. Those three things will allow you to take those low frequency, high risk rescues and have success and good outcomes. So repeated exposure to rescues or airway or critical patients builds competency. I just want to just in the aspect of intubations, the system that I work, and this is not on rescues, this is just street medicine, that in 2022, out of about 13,000 advanced life support runs, we intubated 1,258 patients. We have a first pass success rate of 86.7%, and we achieved airway control via ET tube 99.1%. The remaining 0.9% were 7 LMAs, 1 BVM, which I was part of, and someday I can tell you that story. And we completed 3 surgical airways. So again, successes like this and numbers like this come from doing it often, having a established system, good medical oversight, and a good feedback loop, and lots of training and a good medical culture. On the air rescue side of things, this is an example of our yearly training. We do bi-weekly training every Thursday. 5 of us get to train approximately, and we do 4 to 8 hoists or rescue scenarios per rescuer. So again, we're getting lots of reps. We have 2 biannual in-service days, which last about 4 in total. And we'll do over 200 rescues in that 4-day. A couple months ago in the spring in-service, I think in one day, I personally did 300 hoist missions, or not hoist missions, but hoist evolutions. We have about 20 hours of approximate ground training on top of that. And then our annual response is the 15 to 25 missions annually. So if you can see where the balance lies, train heavily, do it a lot, just for those few high-risk missions and complex. That's what you should be striving for. If you're in charge of a training system someday or a medical program, this is a good place to start. And also, again, feedback mechanism. You have to hear good things, and you're going to have to hear some bad things occasionally. But that just builds you a provider. Airway management starts in the hangar way before the mission starts. We train, like I said, but when the mission comes in, we plan, we check our gear, we double check gear, and we use checklists to guide us through certain critical steps of the evolution. And I know in hospitals and in surgery suites, they'll use checklists prior to that. Airway management is starting to get a checklist culture a little bit, and that's okay if you don't do it enough. But these bring lots of strength and value to your program and assures safety. And the next slide I'm going to show, and let me know if you don't hear any audio, but it should work. Oops, I'm ahead of myself. But checklists, or if you're assigning roles and responsibilities, it establishes a team lead. It establishes clear line of communications. Leadership knows who's doing what. Establishes clear tasks and expectations of every team member, and everyone's cross-trained in that, and we understand what everyone's doing. You want to state what the goal is. We are going to put an ET tube in somebody, or we're going to do this screamer suit evacuation on the cliff, and we'll be out. Set the tone, state the goal and the desired outcome so everybody's on the same page. And if you do this and things aren't going well and you got to go to plan B or plan Z, there's less stress when you're transitioning. Okay, I'm going to play a short video clip of what our checklist is right before we're ready. We've scouted the area, and then we're ready to actually execute the hoist and the extraction. So this is our checklist number 1 that we do.
All right, windshield wiper. It's better than I thought. It's a lot better than I thought. George, you see that straight down there?
Yep.
Eric, you see that?
I got it.
Okay, do your on-scene. It's going to be squirrely, boys.
On-scene checklist number 3, power available versus power required.
I hope 10%.
Wind effects, including turbulence, updrafts, and downdrafts.
It's going to be very bumpy. We're going to come straight in. You're going to keep George tight until I get the feel for the winds in there, and then you can put him down. Be ready to bail out and pull George up.
Roger, I'll keep him tight until you let me know. Aircraft entry and exit routes.
I guess I'd be in from the west and out to the north is what I'm calling it.
Effects of rotor wash on patient.
It's going to be bumpy.
RS traverse route.
Straight down.
Who will fly and hover reference is used.
Main trees.
Assign obstacle clearance responsibilities and crew duties.
You're the SO, George's RS, Bill RS2. We got the front. And Heiko, if you need it, you're calling clearances on the left side rear.
Call to abort. Anybody uncomfortable with the evolution, call to abort on the ICS. PIC intentions in the event of an aircraft emergency and hoist your authority.
Appropriate response. Hirsch has it.
Any questions?
Yeah.
So I hope you guys all heard that. And that's our checklist. Again, right before we do something complex, we've already made a plan. We kind of know what the expectations, but again, we're going to go over it one more time and state what everybody's job and roles and responsibilities are. because when it doesn't go right in air operations, it goes wrong pretty fast. And so that margin of safety we need to build in, because the thing can crash very quickly. There's two methods of hoisting. There's what you probably have seen before is helicopter shows up, stops in one spot, and hoists up and down in a hover. Hovers are dangerous, as the most vulnerable time that a helicopter is at. Forward airflow across the rotor disc, across the aircraft is the most preferred. So what we try to do about 90% of all the rescues is what we call dynamic hoisting. It is kind of like coming in for a landing into an airport, like on a traditional airplane, but at the same time, we're letting that rescuer come out of the helicopter, and at the very last minute, right before my feet touch the ground, maybe 10 feet above, that's when we'll hoist briefly, come off the cable, and the helicopter flies away. And that's dynamic hoisting. Not every air rescue system does this. We've been doing it for close to 20 years now, 15 years. It just increases your safety profile. And here's a quick video of a rescue that we were on in Asgard Pass in the Mount Stewart area in the Cascades. And you will see this is the part where the helicopter is coming back in to pick up the rescuer with a patient. And this is a screamer suit evolution. This person ended up having a busted pelvis. And you will see the helicopter come in, basically parallel park, and the hook will be coming out and pick up. During this time, nobody talks. All my hand signals to the ground. It's really to talk. He's nodding his head. That's the up signal. They will come in, and now they'll fly away here. Hold the victim and the rescuer in as they're flying forward. Paper flight profile. They're at an altitude of 7,000 feet, so that's how high it is. And that's dynamic hoist. So after, let's talk about some more processes. We've talked about airway control. We've planned for medical issues, planned for the rescue side of things. And now we've combining these two disciplines. And this is a video clip of a fall, 100-foot tumble down the side of a mountain of a hiker in the remote North Cascades. He has reports of severe head injury, and it sounded like, you know what, this guy has a Glasgow scale of 3 almost. I think we're going to be putting a tube in him and doing the full boat trauma care. And that was our plan until we flew over and we could see the victims outside, and the guy was waving, and we're like, well, if he can wave from this, or excuse me, if we can see him from, up in the air and 200 feet down below us, he's waving. I think his airway and his neurological exam is intact. So we'll just do a simple screamer suit evaluation or evacuation, and I think we can throttle down on the airway concerns. And even though that we're pretty confident that we got a somewhat stable patient, my coworkers are still going through their mental preparation of their tasks. One guy's talking about, is the O2 ready in his head? IV setup, EKG, difficult airway. Do I need to do a surgical airway if he comes into the helicopter? The other rescue specialist is talking about or thinking about, what his job is. The pilots are up front running, through their minds. Do we have enough fuel? What's the weather like? Are we going to Seattle or are we flying to Wenatchee? And as all pilots think about, they also like snacks. So we try to go to good destinations or airports with good snacks. But this is a video of me coming down out of the helicopter. I'll give you a preview of what it's like on the hook side of things. And again, I'll just narrate what my thought process is at that time. But again, during this time, and even if you're in the hospital and we're managing airways or doing complex tasks, have a sterile cockpit. Operational talk only, or don't talk at all unless it's an emergency. No chit chatter and things like that. That will lead to mistakes and errors and accidents. Again, this is dynamic placement. Put me in the brace position. And I'm looking at the surrounding areas. What are my challenges? What's the mechanism of injury? What kind of airway issues did that mechanism cause? I can still see these two guys moving, but as I get closer, I notice that it looks like Mike Tyson up there. I see a bloody face, and he's a little bit groggy. He's not moving as brisk as I thought he was. But now I'm kind of thinking, maybe I've got more of an airway history than I do. So kind of primed for that, ready to land. And once I get to the ground, I ask myself, what kind of type of airway management is needed? And without any sort of technology with me, except my 5 senses, and this is what I'm going to ask you guys to build on for the rest of your career. And that's why I asked earlier, is like, if you can expose yourself to difficult airways and critical patients as much as you can, this becomes instinctual. You don't need a pulse oximetry. You don't need a blood gas. You don't need an EKG to tell you someone is sick. The biggest thing that will lead to poor outcomes or not great care or fast care is delay and avoidance. You start second guessing yourself. You start hesitating. You know that someone needs a tube 20 minutes ago, and it takes another 20 minutes to finally put the tube in. Avoid that as much as you can. And again, exposure to critical patients is huge. So look at their work of breathing. Look at their skin color. Are they breathing with accessory muscles? What's their breathing pattern? Is it chain Stokes? Is it slow, fast? What's the rate per minute? What does it sound like? Without even taking a stethoscope out, are they snoring, wheezing, stridor, gurgling, rolls, coughing, bubbling, all that stuff? And once you finally put a stethoscope to that chest, is it quiet? Or is it full and it sounds great? And you go, oh, okay, the guy's got great lung sound. I can relax a little bit more. Are they talking in 1 to 2 word sentences? And when you're feeling their chest or you grab their, you're doing your exam, what's the skin temperature like? Is there sub-Q emphysema on the thorax? If you percuss their chest, does it sound hollow? And you're also looking at their level of consciousness. Are they smiling, talking, combative, quiet acting? Are they so hypoxic that they're just sleepy and tired and they needed that ET2 5 minutes ago? You can do all of this if you've seen it often and you recognize that you don't need technology really to do this. RPD in there in the parentheses is called a recognition prime decision making. You can look that up. It's from Gary Klein. It's a process that he talked about 40 years ago, almost in books. And that's kind of the benchmark that you should start with. And when do we protect airways? During CPR, Glasgow Coma scales of less than 8, an expected clinical course, person with obvious respiratory failure, and loss of airway reflexes. Those are the top 5 points to start. There's definitely some other ones, but again, this is kind of the top 5 that we want to deal with. I'm not going to go too in depth about those airway management types. I think because some of us may be exposed to that, but you'll learn more about that as much as you can. Advanced airways are ETs with intermittent positive pressure ventilation. There's laryngeal mask airways. There's surgical airways. The basic airway, which we should all learn first and be masters at it before we go on to the advanced side, is the bag valve mask. There's oral airways, nasal airways, supplemental oxygen, and suctioning. You can't have advanced airway without basic airway. I call the chest the other airway. So look at the chest, because you can manage the upper airway, and if the chest is not intact to exchange gases to ventilate that patient, then it's not going to work. So do they have a pneumothorax, hemothorax? Is there a flail segment? Do they have blunt force trauma? And do you need to do a needle decompression, positive pressure ventilation, or a chest tube? Those are all those things that we can consider. And even if you don't have obvious signs, again, look at that mechanism of injury. And this gentleman here did not survive this injury. He had large hemothorax or hemothoraces. He internal bleeding in his abdomen, but that seatbelt sign there is an ominous factor. Those patients who talk to you, they look kind of good. Create that safety net of vigilance, 2 IVs, supplemental oxygen, airway control. And when they crash fast. And if you're ready for that, your meaningful care will save the day. If you need to take an airway with rapid sequence intubation, pharmacologies come into play. So again, there's all kinds of drugs to do that: ketamine, etomidate, paralytics. So, but again, remember, we're going to disassociate that patient from the event. We're going to paralyze and relax their muscles so we can facilitate intubation and ventilation. And then once they come through that, we want to sedate them and give them some pain control, and that's a must. But before you get that, ask yourself, do we need to stabilize their vital signs or correct hypoxia, hypercarbia states beforehand? Because if you just come willy-nilly in there, give them lots of drugs in a hypotensive shock state or hypoxic state, and you dump drugs in there, they're gonna crash on you. So let's bring up their CO2. Let's drive down their CO2. Let's bring up their SpO2. Stabilize their blood pressure with some push dose epi, and then put the tube in. And this is very difficult to do in the wilderness. Not only if you get it done, which you can, but how long are you going to be out there, and how much pain meds, how much paralytics, and can you sustain that and have enough supplies to keep that patient ventilated, because things go south and unexpected things happen. Once you've secured that airway, it's vital to maintain it. And we do that through end tidal monitoring. We can do that through a litmus paper on the easy cap there. That's what I keep in my pocket. Initially, I will intubate somebody with that because I don't always bring my monitor down that has the end tidal on there. So that's my verification, and continue monitoring placement until I get into the helicopter, and I'll switch over to the normal machine. There are inline monitors, and then there's a basic life pack. Then make sure you secure it good. You do not want to lose that ET tube and have to re-intubate somebody. That is not a good day. It can cause damage there. So get a good securing device. So now the hard part: how will you maintain the airway during extraction? Well, first of all, let's focus on that airway, on that ET tube. Again, let's not pull it out. Let's make sure your crew member, your other team members understand that is a thing that we're not going to take lightly. We're not going to pull it out. You saw the screamer suit evacuation, and that's one method. It's just like a giant jacket with a diaper, and we come up together, and we can put that on super fast in very steep environments without coming off the hook, and snatch and grab people pretty well. There are litters. There's all kinds of different litters out there, but some of the must-do practices is that person must be secured to the litter. There's a litter spin or a tip, people fall out. And if you look on the accident report websites around the world, there are lots of people falling out of litters. So if you ever find yourself in there in a country that maybe is not that does a whole lot of rescues, make sure that they strap you in. Now remember that rotor wash is about 50 miles an hour down, and it may be a 40-degree day, but it becomes 16 degrees very fast through the wind chill factor, and even colder during times. So cover your patients, protect them from hypothermia. Litters, we usually don't, the litter that I'm going to show you in this video, we usually don't fly with this very much. If we do use this litter, it's because we're coming into another team and assist it. I'm going to go back one slide. That litter that you see on the left-hand side of the screen is the one, we call it the Airway bag. That we don't need a tagline, even though you see one in that picture. As long as we have maintaining forward flight, that will not spin. So we tend to use that litter more than the hard Stoke style basket. But here is just a quick example of tagline operation. There's a person on the ground putting a little bit of tension on that line to make sure that litter doesn't spin around. There is a 100-pound pressure or PSI, or 100 pounds of force break link. So if you pull too hard, you can break the link. If the helicopter pulls away or something gets stuck, that link will break, and that's why we put it in there, because we never want to be connected to the ground by a hard point. I can pull that helicopter through the sky. That's how it's, even though it's very powerful, in a hover, you can influence the flight characteristic. If a rescuer is attached to a hard anchor on a tree or on a rock anchor, and that helicopter has downdraft or some sort of turbulence, you can do a dynamic rollover and crash that helicopter. So that's a very vital portion of that rescue thing. And here is a litter spin. We do practice occasionally, litter spins. Not my favorite thing to practice. I only do that once. Taglines do fail because we want to give an idea of what a litter spin is like. I think it's a good way to get rid of embolic strokes in your brain, just by spinning, pushing down on your feet. But imagine that you have an indicator or you have a patient that has been a little bit nauseated, and then you start to spin. What kind of airway control it? That was not fun. So things that can go wrong during the hoist. So now you've managed the airway, whatever that is, an advanced one or a minor one, and you think you're home safe. The winch can break, and now you're stuck, and you have to fly like that. There is an emergency cable shear, and like I talked about the tagline in dynamic rollovers, you are once you're on that cable, you're the least important person in that evolution. If it becomes between crashing the helicopter and getting you unstuck from a tree or a rock, we will shear the cable, sacrifice the rescuer, and recover the aircraft. And that's something as a rescuer that we all have to accept. Doesn't happen, has never happened in my career, but or in our agency, but around the world it does happen once or twice a year. Yeah, the cable is sheared through an explosive bolt in the winch, and there's a process, and you heard in that checklist that we do, there's a process that who has control of that, and that's usually the co-pilot, and then the pilot is the backup. There's a button that you have to activate to shear the cable. Could be a loss of comms. You have to stay on the ground. Maybe we've lost fuel, there's weather, and they can't come back for you, and now you got to take care of that patient for a lengthy period of time. Is there a crash or an emergent unattended landing, which I've experienced once before? That is not fun, and now you have patient care on top of a emergency landing in the middle of nowhere. The patient vomits, and that's not fun during that hoist period. How do you get someone on their side during that time? How do you suction? You don't. Let's talk a little bit about altitude physiology. If you start going about 2,000 to 3,000 feet in an unpressurized cabin, or even a pressurized cabin, because cabins are pressurized on airliners to about 8 to 10,000 feet, ET2 cuff, excuse me, endotracheal tube cuff pressures will increase and damage the trachea on hand. So the way around that is putting saline in that cuff when you inflate it, which is sometimes a challenge. But if you don't do it, just monitor your ET2 cuffs if you have to go high altitude, and then make an adjustment accordingly. Pneumothoraces can worsen for the same reason. And this doesn't happen very often, but it's something that's on air rescue's radar, is air rescue agencies that maybe start close to sea level and they find themselves at 15,000 feet within 20 minutes of the mission call out. You can get cognitive decline during that. So there's a little bit of, it's on people's radar. They're trying to do some studies to see how much decline there is. Ground safety, and I'm only going to tell you 1% of what you need to know about ground safety because there's so much to know and to do. People absolutely, for some reason, lose their minds around helicopters. Professionals and volunteers and the public. I like it. I love helicopters. They excite me. I get crazy a little bit too. But if you are part of a rescue operation, just awareness, keep your head cool and calm, and keep your head on a swivel. Make sure you are looking around and following instructions. Loose items can need to be secured. One mission, we've done 2 this year where tents were involved. Even though we're 200 feet up in the air doing a 200-foot hoist down, we need to put people in the tents and hold them down, secure those items. A piece of plastic, a plastic bag, can take a rotor out and crash the helicopter. We want to approach the aircraft from the front. All the aircraft air crews instructions. If there's landing on slope, if you're landing on the ground and the angle is sloped, the ground is angled or sloped, don't move and watch the air crew. They will direct you on what side to come. That changes the pitch of the rotor disc, and you can see how far that rotor disc or that blade will come down in the picture to your right. So don't move, don't walk toward it until you get instructions. Secure the landing zone as much as possible. Physically put people around the perimeter of that landing zone and make sure you don't lose that integrity. We told people not to come toward this area, and their dog got loose, and that dog ran straight for the helicopter, and that little dog would have been just fine, but the 2 owners ran straight for the tail rotor. I thought I was going to see people killed and a helicopter destroyed, but we were able to intercept them. No drones in a ditching spot. What wasn't said in that checklist, and we added this a few years ago, when we're coming in to do the rescue and going through our checklist, we identify a crash spot, a place that we think is the most survivable place to put the helicopter and crash. 95% of the time, the ground SAR people put themselves right there. They don't know that, but they all got their phones out, taking pictures. I know I'm guilty of it too, but please be aware, and don't be surprised if over the radio that if you're working with us, we'll ask you to move because that's where we're going to crash. If we crash, we're not going to crash. So almost done here, kind of coming toward the end. I sent emails to 5 of my ER physicians that I consider mentors and close friends. And because I don't want this to be totally about me, this presentation. And so I asked them if you can go back to your med school person and the airway training that you had, what do you wish that someone would have taught you? So here's some of their tips and tricks that they gave me. So large BVM, bag valve mask, tidal volumes can do damage. People get excited, they ventilate someone way too much, and that's detrimental. I use a large suction to get crusty secretions and blood and vomit. The tiny tips don't cut it. Make sure you're comfortable with old school Mac blades. Video laryngoscopy screens break, batteries die, and they don't work. That is the universal comment from all 5 physicians. So I know they're out there teaching VL innovation. It's okay, it's great. I don't have it in the field for a very good reason, and that's why. So don't lose the old dark arts. Keep your ET tube in your jacket in freezing and cold environments as you're going to the victim in a rescue. Keep that ET tube warm. Those get super hard. They can break. My friend who works in Alaska, she was doing a resuscitation in minus 25 degrees, and her ET tube broke in half. That's how cold it was. So keep it warm. It keeps your patient from getting hurt too. Keep items secured. Things roll away in the mountains and blow away too. Learn the one-handed suction technique. Learn to scope and suction tip in the left hand. Apparently there's a YouTube video on that. And this is one of the ones I think is most important. Kira, this is from CVT. I went straight to learning how to intubate. I wish we would have learned how to properly BVM ventilate a person first. You can't have advanced airway without basic airway. So some final thoughts before we conclude here. And these are just some of my random thoughts that I had as I was coming to close. Always strive to expose yourself to more airway management scenarios. Go out and see sick people. Don't take that easy shift. Work the nights, work the busiest ERs or the busiest clinics you can, and early in your career, you get to relax later, trust me, and get a lot of experience underneath your belt with airways. Be calm during those critical situations. Establish roles and duties. And are you waiting for air rescue? I want you to realize that it's a complicated and dangerous endeavor. We'll make it happen. We put our best people in air crews or in air rescue teams. If they don't show up or they call the mission off, there's a really good reason that it's getting called off. And it's usually for safety, ground and air crew safety. So plan that it's potentially not going to happen. So you may stay with your patient a lot longer than you had anticipated. And if the airway is not taken care of, the other treatments don't work. So get out there, secure that airway, and then worry about the rest of it, and you'll be fine. Questions?
Feel free to unmute yourself to ask questions, or you can drop them in the chat and we'll read them off for you.
I'm going to reduce should I stop sharing my screen? Or?
Yeah, you can totally stop sharing it, or you can keep it up. That's totally your preference.
I'll keep it up just in case someone wants to go back to one.
We had a comment from Dr. Davis in the chat. Said he's an ER physician, former EMS, SAR, and the Fellowship of Wilderness Medicine. Agree with all the tips and tricks, especially number 3 in the last one. Also learning multiple methods and backups, and the bougies save lives.
Bougies always in my pocket.
It looks like we have a question from Steven.
I have a question. Oh, go ahead.
Hi, how are you doing? I just wanted to know if you could elaborate on different hand techniques that you felt were helpful with controlling a Mac or Miller.
Different hand techniques. Wow. It's a good question. I'm probably sure that there is ones out there. It just goes in my left hand like this, and I've always just kind of treated it like, cheering with a glass of wine or champagne or lifting up. I'm not too, that's a great question. I've never really had to switch my hand technique. So sorry, I'm not help on that one. I think
I can make a brief comment
if
if it's okay. I'm
emergency physician and wilderness physician in EMS, I really think about the tip of the blade and engaging it into the depths of the vallecula so that the hippocampal ligament is engaged to lift the epiglottis so that you can see the glottis. I think of the blade as an extension of my hand and arm, sort of mentally. I know it sounds weird, but it really works. And it's a game of like a millimeter to get a better glottic view.
Yeah. And kind of go slow and, go through your steps and don't go in there with a whole lot of force and gusto. It's a gentle, purposeful movement.
Yeah, it's a finesse thing.
Yeah.
I believe Susan had a question next.
Hi, I have a question. This is Susan from Northwest Montana. I might have missed this, but it sounds like is your job duties twofold? One, you're with the county SAR, and then you do street EMS.
My full-time job is with King County Medic 1, and about 12 years ago, the King County Sheriff, they never had a medical component on the helicopter. They just did pickoffs. They wanted to up their game. They came to the other county agency, which I'm a public health employee. We're a third service EMS. So there's only 6 of us medics from the street side that are cross-trained as rescue specialists on the air team. So it's a great synergistic county function that we provide for all the state of Washington.
Yeah, that's pretty amazing. So are you like the only kind of show in Washington?
No, we have great partners. There is Spokane that just is a brand new operation in the last 2 years. They have the same model as we do. Snohomish County has a ALS capable helicopter, but they're staffed by all volunteers. And then we have the U.S. Navy from Whidbey Island. And we all practice together once a year for sure. We all get together and do a big remote MCI evolution.
And are those mixed of county funds and private, or is it all through
all public dollars?
Yeah.
Yeah. The Snohomish County one is funded through volunteer donations. But the rest of us are all staffed by, full-time employees. Between the pilots are deputies, and they've been all trained through, flying. And the non-paramedic rescue specialists are deputies that are cross-trained as rescue specialists also.
Yeah, it's pretty special because I'm sure you're familiar with Two Bear Air here in Northwest Montana, but those guys can't do medicine. So they're strictly rescue, and you guys have the capability of doing everything.
Well, there's a good restaurant and lunch in Spokane, so if you ever need us, we'll come over there, but we'll have to make a stop first.
Thanks.
Yeah.
Heiko, do you want to talk a little bit about your path to becoming like a flight medic?
Yeah, that's I've been asked that before, and this is it's different. You have to be a paramedic first. We don't accept outside certifications, so we'll put you through the University of Washington Harborview Medical Center training, and then you got to come out and you got to work for a minimum of 5 years as a street paramedic, and then it's an invite for paramedics and for the deputies also. It's pretty much an invite only endeavor. If you're invited, and if we have a vacancy, it's about a year of training, and then you go through an evaluation process to whether you can be on the team or not. So it's very difficult for someone to say, this is what I want to do. I just won the job lottery and got lucky.
So then for possibly someone coming into the field, what piece of advice would you give them on just navigating the whole system? because that's different than how it is here in California. So
Yeah.
if it was coming into Washington, what would be your piece of advice?
If you want to do wilderness rescue medicine as a physician, and if I had to do things over again, I would go to Europe and do it. I don't think the United States has that established programs to where a physician can fly professionally and make at least that I know of, right? Make a living off of it. Most of the mountain rescue stuff, as Kira and I know, is done by volunteers. We do have physicians on the team, but you're not earning a living. Now you can go to an air ambulance service and do, like Airlift Northwest or these other private air ambulance companies, and you can do just fine there. But strictly to work by yourself or with another rescue person on a mountain, I go in the military. That's the other part. And just the U.S., I don't feel like or is set up to offer a career in that. I don't think Canada is either. It's hard. It's few and far in between.
Hi, it's Sue again. I have another question for you. Out of
Sure.
all those missions you've deployed to, how many times personally have you had to do an advanced airway on someone?
On the helicopter, never.
Okay.
But in other technical environments, yes. Or I've walked in, I had a walk-in. It's one of two things. They're either expired and they're dead and you don't need to put an airway in because the distances in the state of Washington are so far, as you know, in Montana, it's too late. But have I walked in or been rappelled down the side of a canyon? Yes.
Thank you.
Mm-hmm.
Any last questions for Heiko here?
If there's any questions, I think I put my email address on there, but Kira has my email, so you guys can email me later if you think of something or some other advice, or happy to help out.
Yeah, thank you so much, Heiko.
You're welcome. I hope you guys liked it. Anyways,
Thank you
okay.
again, and thank you everyone for coming out. We really love seeing everyone interacting. Remember that we have another talk on September 4th. I believe it's at the same time. But as always, have a great rest of your day, and this recording will be uploaded for those who've been asking for the videos.
Thank you. Great presentation. Thank you very much.
Thank you.